بسم الله الرحمن الرحيم. يعني أولا بنعتذر عن التأخير. ثانيا نحب نقدم دكتور باسم وهبة، مدرس الأنف والأذن في القصر العيني ومستشاري جراحات الأذن الحنجرة وجراحات الرأس والرقبة في بريطانيا. حاليا هيقدم لنا محاضرة بعنوان مانجمنت اوف ثايرويد كارسينوما البيست ابروتش.
السلام عليكم. الصوت سامعني ولا
باسم
اكمل؟
اتفضل دكتور باسم.
السلام عليكم جميعا. انا باسم وهبة، اسيستنت بروفيسور في كايرو يونيفرسيتي. النهارده هنتكلم عن المانجمنت اوف ثايرويد كانسر. انا مش عارف الناس بتحب تتكلم ميكس عربي ولا انجليزي ولا كله انجليزي، ف هبروسيد وشوفوا انتوا عايزين ايه يعني. Thyroid cancers, it is one of the entities that subspecialties in ENT and head and neck cancers. And I believe we have to give more attention to the thyroid cancers. It has been for long decades covered by the general surgeons. And I think the time, and in many countries now, most of the countries now, it is now shifted to be an ENT subspecialty, and I think it's very important to keep it in the ENT, especially when the general surgeons now are very busy with the plastic and bariatric surgery. So it is the time to overtake the thyroid surgeries. Regarding the epidemiology of thyroid cancer, we can say from 100,000 population, you can find 3 people have thyroid cancer. In females, more common than males generally, and it's about 2 to 3 to 1 ratio. And also, it has increased in the United States as well. And you can find about 14 patients from 100,000 population have thyroid cancer. Annually, there is about 1,000 patients with thyroid cancer in the United Kingdom. 250 deaths annually in the United Kingdom as well. So it is generally something that we have to keep attention for. Actually, when thyroid cancer, thyroid is very common, and thyroid nodules are very common. And when we see the patients in clinic, we are telling them that if we randomly do ultrasound for people in the streets, you will find 50% of the population have thyroid nodules. So it's a common thing. 50% have thyroid nodules. 5% have palpable thyroid nodule, and 5% of these thyroid nodules are cancerous. So 95% are benign. So it's very common thing. It is a benign thing mainly, 95% benign, but 5% there is a chance of malignancy. Thyroid cancer becomes the most common malignant endocrine tumor. In women, it is the 3rd most common cancer in females. And in some statistics as well saying that it's the 5th most common cancer in females. Recently, in the last decade or so, we can say that there is increased chances of thyroid cancer. And that's because of many reasons. One of them is because of increased facilities for the diagnosis. Now it's easy to do ultrasound, easy to do fine needle aspiration cytology, so easily picking up thyroid cancer in its in its beginning. Also, what's happened, I am talking about Europe, and in Europe in the late 80s, Chernobyl as well, Chernobyl explosion also increased the risk of thyroid cancer every year. Like we have few patients, maybe not too many, but like we have I've seen like 3, 4, 5 patients each year from Chernobyl explosion has thyroid cancer. So it has increased globally as well. The risk factor, so there are important risk factor. The most important questions I'd like to ask the patient is about the family history. Either the patient personally has thyroid follicular adenoma, or there is first-degree relatives or second-degree relatives have thyroid cancer. The chances of thyroid cancer in that individual increases by 4-fold if there is positive family history or positive thyroid cancer in the family history. And even the papillary thyroid carcinoma or follicular thyroid carcinoma, some of them have mutation has been found as well. But of course, the most common familial thyroid cancer is the medullary thyroid cancer, though it is itself is rare, but it is the most common familial thyroid cancer. But the chances generally of thyroid cancer increases by 4% if there is a positive family history. Also, the NEC radiation. The NEC radiation, it increases when there is a nodule in the thyroid, in the background of NEC radiation, the chances of that nodule to become malignant becomes like 40%. And the aggressiveness of the tumor when it is in the background of irradiation, it's much more aggressive if you compare it to the non-irradiated thyroid nodule. The other thing is, it's important that's why it's important, especially in children, when we have a children needs a scan, we are trying to minimize the CT scan as much as possible, because according to the American associations, radiological associations, they give that in our lifelong, we are, I mean, we can take up to 100 units of radiation in our lifelong time. If you expose, for example, a CT scan chest or CT chest abdomen can give you like 7 units, 8 units. If you give it to a child and the child has a span, his lifelong span time, he may have in his future some chronic diseases which requires repeated CT scans, or cancers in the future which repeated CT scans. So the exposure of the CT scan will be too much, and this increases the risk of cancer. The CT scan for a single CT scan, it causes a cancer, is very, very minimal. It's less than 0.5. So it's very rare to have a cancer from NEC radiations. But of course, if you expose the patient to NEC radiation and over time, especially in children, over time and over their years, this increases the chances of malignancy later in life. The endemic goiter, it's not anymore, it's rare to cause thyroid cancer, maybe 3% or so, but it's previously, even in the previous decades, endemic goiter, because of the iodine deficiency, may cause increase in the TSH. This over time may increases the or cause stimulation of the thyroid, and this cause like a chronic irritation, and this may cause thyroid cancer on the long term. But this is quite rare nowadays, because even in the states or in the countries which have iodine deficiency, they are compensating that with increasing the iodine in diets. Hashimoto's thyroiditis as well can cause lymphoma. Thyroid tumor as well. Thyroid tumor itself, it doesn't cause any. It is not a lymphatic tissue. It is formed of follicular cells and parafollicular cells or C cells, which secrete the calcitonin responsible for medullary thyroid cancer. But it is not a lymphatic structure. But with Hashimoto's thyroiditis, there is a lot of lymphatic infiltration, and this, on top of Hashimoto's thyroiditis, there is a low risk of transformation to lymphoma. Cowden syndromes, like the Cowden syndrome, also it is rare. Every year I see 1 or 2 cases of Cowden syndrome. It is a kind of syndrome which has, skin deformities, hematomas, thyroid cancer, breast cancer. The patient has some retardation as well, but yeah, we can see these, and they have this characteristic scrotal tongue, or we call it carbotile tongue. The other syndrome is familial polyposis, can happen as a part of the Gardner syndrome. The Gardner syndrome has the increased chances of thyroid cancer and familial polyposis or colonic cancer as well. Obesity, it's not by itself a risk factor, but maybe more like an association with the thyroid. I would like to highlight some of the key recommendations. It's important that we think or change our thinkings about thyroid cancer. Key recommendation means these items should be highlighted and should be taken into consideration in our decisions. The difficulty in thyroid cancer is not about the surgical skills. Surgical skills is easy. I think if you do too much thyroid, you will become expert. But the problem is the decision making. The decision making is sometimes it's not straightforward, because many cases of thyroid cancer lacking a strong evidence of what to do in that situation or that clinical scenario. So we have to have some sort of multidisciplinary team. So the key recommendation that we have to do, have MDT, we have to have some sort of staging system. I've used the TNM staging system, and the recent one is the 8th edition. We're talking about the prognostic factors as well. Key recommendation is use a scoring system and ultrasound as well. There are different scoring systems. I come through later. Also the fine needle aspiration cytology. The key recommendation is to use numerical scoring system as well. It's not just a description. And we'll talk about what's called risk stratification and dynamic risk stratification and what's called personalized decision making. I will explain that in details later. First of all, MDT. It's important to have an MDT. You are not justified to give a decision on cancer without having a multidisciplinary team. It's medical legal as well, because you have to have some sort of, even if in Egypt, if we don't have a formal MDT sometimes, you have to find some of your colleagues or peers who have interest in thyroid cancer, a surgeon, and oncology, which also has an experience in the radioactive ablation and radioactive iodine. And you have to find a radiologist and pathologist. All of them have interest in the thyroid, because sometimes difficult to read the scans, sometimes difficult to read the cytology. So it's important to have a multidisciplinary team. With a multidisciplinary team, you will have the best outcome for the patient. It's not about, as I said, it's not about your skill or what you will do for the patient, but what the patient-centered decision, what's the best outcome for the patient, and this will be obtained only by the multidisciplinary team. And I think it's now in the corona time, it's very useful to create like a virtual MDTs. You can find some of your friends that you have a formal MDT virtually through this webinars and so on. Then the second thing is the TNM staging. Of course, all of us using the AJCC, the American Joint Commission Cancer, the 8th edition. Sometimes I know, especially old school, don't use staging for the thyroid. So they just diagnose papillary thyroid cancer, so go for treatment, follicular thyroid cancer, go for treatment, but we should have a staging system. And there are different staging systems, TNM, the tumor size, and the lymph node metastasis, the distant metastasis, but the thyroid has differences in TNM staging than the other types of head and neck cancer. In addition, we depend on the thyroid cancer and the size as well. I mean, like many of the head and neck cancers, maybe some exceptions, like in the larynx, for example, you depend on the site, not the size. But in the thyroid cancer, we're depending on the size of the tumor. But also into consideration, which make a difference, is the age of the patient. And this will take into consideration our decision. And also the completeness of surgical resection. We call it like residual tumor or no residual tumor. We abbreviated by R. So if there is a residual tumor, this will affect the staging. And there is no residual tumor, this also means a good prognosis. The grade of the tumor as well. Sometimes some of the staging systems using the grade of the tumor to identify what is the staging and the prognosis for the patients. So they are different, and that's the European one as well. So we have different things, but in thyroid, what is characteristic of the thyroid, that we use the TNM in addition to the age, in addition to the residual tumor, to make a decision about the staging and so the prognosis. I will give a brief about the TNM staging. It is like any other head and neck cancers. We usually say if less than 2 centimeters, so it is T1, but we subdivide that into T1A and T1B. T1A, which we call it the microcarcinomas. The microcarcinoma, if it is 1 centimeter or less. But if it is between 1 to 2 centimeters, it is T1B. But overall, the T1 is less than 2. T2 is 2 to 4 centimeters, and T3 is more than 4 centimeters. And here there is a difference between version 8 and version 7 of the AJCC. In version 7, there are just T3, but in version 8, they subdivide that into T3A with tumor more than 4 centimeters, and T3B when there is some extrathyroidal extension. The T4, when there is more extrathyroid extension, extends to the larynx, to the trachea, and T4B, like any other types of cancer, when it is tumor resectable, very close to the carotid and very close to the prevertebral fascia. The lymph node metastasis is different from the other head and neck cancers, as it has no N1, 2, and 3, just N1 and N0. N0, no lymph node metastasis. N1, subdivided into 1A and 1B. I think there is a mistake here. Oh, no, that's right, yeah. N1, when there is a central compartment of lymph nodes, because thyroid in the midline, so we're expecting if there is extension will be in the central compartment. And what is meant by the central compartment is level 6 and level 7. Level 6 is the prevertebral, pretracheal, prelaryngeal lymph nodes from the hyoid till the level of the suprasternal notch. And then that level 7 is the anterior superior mediastinal lymph nodes, which is from the level of the suprasternal notch down to the brachiocephalic artery. Further extension to the lateral lymph nodes, it's called N1B. So there is no N2 or N3. And the most common lymph nodes affected in thyroid cancers are level 2, 3, 4, and 5B. We'll come to that later, but I'll just give a briefing about the TNM staging. As I said, there is residual tumor. One is microscopic residual tumor. It means when we remove the thyroid and we send it for histopathology, and so the histopathologic examination find microscopic residuals. There's no margin. I mean, there is infiltration of the margins. That means there is a microscopic tissues or microscopic cells in the thyroid bed, and it is R1. R2 in the macroscopic, when there is a gross residual tumor in the thyroid bed. Again, we are adding the age in the staging system. So before in the AJCC edition 7, the cutoff age was 45 years. But in the version 8, it is 55 years is cutoff age. And the thyroid cancer has a very good prognosis, very, very good prognosis. So in patients less than 55 years, even if you have distant metastases, they are still staged as stage 2. So if you have a patient come with a thyroid lump with pulmonary nodules, distant metastases, and his age is 40 years, he is in stage 2 cancer with a prognosis up to 95, 97% treating, completely cure. But however, after the age of 55 years, it comes back to the normal, staging, stage 1, when it is T1 and T2, stage 2, when you have a lymph node metastasis, whether it is in the center compartment or lateral compartment, stage 3, when there is extension to the surrounding tissues, and stage 4, when it goes to the carotid and the prevertebral fascia or distant metastasis. Even though in that region, we're still in stage 2, 1 and 2 and 3. We have prognosis and 10-year survival rate up to 97%. So in the first 3 stages, we have a very good prognosis. And even stage 4 in thyroid cancer is not bad, 70%. Maybe it goes down with the distant metastasis down to 60%. But generally, if you compare to the other types of cancer, the head and neck, this has a very good prognosis. I'm talking, of course, about the differentiated thyroid cancer. The things are different with the medullary thyroid cancer and anaplastic thyroid cancer. We'll come to that later, not to waste time in this. Okay. Some terminology I would like to highlight as well. When we see the letter P, it means pathological. This means this after taking the thyroid out and sent for analysis for histopathology, then they may change the staging system, not the system, staging, level of staging. For example, if you have a thyroid nodule and you thought it is papillary thyroid cancer and you take it out, and then when the histopathology analyzed that and found that it is anaplastic cancer, that changes the staging. Because papillary thyroid cancer, if it is 2 centimeters, it is T1, but if it comes back as anaplastic cancer, it changes the staging. Anaplastic is very bad. Anaplastic, I will see here, there is no stage 1 or 2 and 3. Anaplastic is the worst. It's starting, if you have a T1, it is stage 4, already stage 4. So it has a very poor prognosis. And if we are talking about 10-year survival rates in differentiated thyroid cancer, in anaplastic thyroid cancer, we talk about 1-year survival rates. So it has the very, very bad prognosis. I've seen few cases of anaplastic thyroid cancer. It is a nightmare. The other thing which I like to also highlight is when we have the letter M. Letter M means it is multifocal tumor. So if more than one focus, also this may shift or swing our decisions when we take some some decisions regarding doing hemothyroidectomy or total thyroidectomy. We'll discuss this later on, but I just would like to want to highlight the terminology here. Then we have the prognosis. I said that for differentiated thyroid cancer, the DTC. So the first stage is up to 99%, 10-year survival rate, and 75 in stage 4, and down when there is a distant metastasis is 63. What are the prognostic factors? So if we have a patient, young patient, child, maybe in the first decade of life or second decade of life, has a thyroid nodule, I have to worry. If you have a patient above 55 years old, I have to worry. Maybe in the middle age, that's fine, but the prognostic factor getting bad if it is you too young or too old with thyroid cancer. Also males, when males have thyroid cancer, have generally poorer diagnosis if you compare to females. The TNM staging as well, we have said, the size of the tumor, when the size is bigger, the prognosis worse, and the lymph node and distant metastasis, of course. And histology, special types, the papillary thyroid cancer has the best prognosis, followed by follicular thyroid cancer, and followed by the Hürther cell cancer, and medullary thyroid cancer, and the worst, as I said, the anaplastic carcinoma. There are certain types of papillary thyroid cancer, subtypes of papillary thyroid cancer called the tall cell and columnar cell, diffuse sclerosing. If there is poor differentiated elements in there, all of these histopathologically, this makes the tumor has bad behavior or more aggressive. So what is the workup? So we have here a thyroid nodule. We have to come to the clinic. So when we are talking about thyroid in general, we have to ask the patient questions about the functions of thyroid, whether it is hyperthyroidism or hypothyroidism symptoms, overactive or underactive thyroid, about the size of the thyroid, if it is large, cause any compressive symptoms or retrosternal extension, the patient has dysphagia or dysphonia or dyspnea, and also whether this nodule is cancerous or not. So these important 3 questions I have to keep in my mind. So what's the importance of the function? Because if the patient has overactive thyroid and underactive thyroid, it is more like an endocrinological problem more than a surgical problem. And the other thing is, cancer is less common when you have a hyperactivity status or underactivity status. It's very unlikely to have thyrotoxicosis and thyroid cancer at the same time. Very unlikely. So the most common thyroid cancers happens when you have the euthyroid status. But if you have an overactive, underactive, that makes you think, it's more likely it's not cancer. Not necessarily it is an exclusion criteria, but it is, generally a good reassuring sign. You will ask about the Horton's voice, and you will examine, of course, the voice box, the vocal cords, because of the tumor invading the recurrent laryngeal nerve or not, or if there is any direct extension, which happens with the anaplastic thyroid cancer, any direct extension into the larynx. You will, of course, ask about the family history, as I mentioned earlier, if there is any neck radiation, any family history of thyroid cancer, and you have to palpate the neck as well, see if there is any lymph node metastasis, any how is the firmness of thyroid nodule, if it is hard or if there's something firm and looks like a benign or cystic. Because if there's a purely cystic thyroid cancer, thyroid nodule, most likely it is a benign thyroid nodule if it is purely cystic, completely cystic. Then after that, I would send the patient to do a thyroid function test, as I said, to identify whether it is euthyroid or overactive, underactive, and the ultrasound. And I send the patient for ultrasound plus fine needle aspiration cytology. Few institutes may say, okay, we'll do core biopsies, not fine needle aspiration cytology. Myself, I would recommend, and I think it is the majority of hospitals do fine needle aspiration. It has a better results and accurate results more than core biopsy. I'm talking about the thyroid. Anything in the neck, apart from the thyroid, apart from being vascular, but anything in the neck, I think, have better results when you have a core biopsy and not the fine needle aspiration cytology. So if you have a lymph node, the better results will be getting better by the core biopsy. But thyroid only, the fine needle aspiration cytology is better. You can extend the investigations if you are high suspicion that it is cancer, a thyroid nodule, and you would like further information. You may request a CT scan or MRI. I would rather always do MRI of the neck and CT scan of the chest. But if you are suspecting cancer and you're expecting to do a surgery for that patient, and most likely a patient with a big lumps and neck metastasis and so on, and you're requesting CT scan MRI for those, think that this patient will require a radioactive ablation, radioactive iodine treatment later on. And if you give him a CT scan, you have to write down it should be without contrast, because if you give contrast, which is iodine-based contrast, and this will block your thyroid, the patient thyroid, because the thyroid tissues will take the iodine from the contrast. And when after 2-3 weeks, when you want to you do the total thyroidectomy, I want to do ablation, radioactive ablation. The radioactive ablation, which radioactive iodine, it will not be uptaken by the thyroid, because it's already, the thyroid tissues has taken the iodine from the contrast. So you have to do a CT, if you are planning to do a treatment for that patient within 8 weeks, you should do a CT scan without contrast. But if you give a contrast, you have to wait 8 weeks till you do the radioactive iodine. More other investigations. So thyroid antibodies, not necessarily do that. It's not of that diagnostic value. If you'd like to diagnose Hashimoto's thyroiditis and you have suspicion of lymphoma, you may ask for that, but it's not a great value. For medullary thyroid cancer, it most commonly come with as part of endocrinopathies, with like multiple endocrinoplasia, type 2 or type 3. So you have to do the workup for the multiple endocrinoplasia. It may be associated with pheochromocytoma, with that's why you do the 24 hours urine epinephrine and metapinephrine. And for hyperparathyroidism, you do parathyroid hormone and calcium. And calcitonin level as well. For lymphoma, you can go then. The lymphoma is the only thing that you can go for a core biopsy, because the fine needle can sometimes diagnose lymphoma, but can't give the type of lymphoma. The core biopsy can, and of course the open biopsy can. What's not recommended is do a preoperative thyroglobulin. Thyroglobulin is the tumor marker that we use to for surveillance afterwards, after the surgery and the treatment. We do thyroglobulin as a tumor marker follow-up. There's no value of doing that if you detect the baseline thyroglobulin before the operation. It has no diagnostic prognostic value. Why? Because when we do the surgery, the thyroglobulin is produced by the normal thyroid tissues and the cancer thyroid tissues. So when you do total thyroidectomy, and so you remove all thyroid tissues, which has the thyroglobulin, and after that, there are some thyroid remnants. You do a radioactive iodine afterwards. This will kill all the thyroid tissues. So your aim is to get like a non-detectable thyroglobulin post-operative and post-radioactive ablation. That's your aim, is non-detectable thyroglobulin. So you make it like a factory setting for the thyroglobulin. And then after that, follow up 6 months afterwards, or annually, or after a year, you do an annual thyroglobulin. So you can detect the difference between after the treatment and later, if rising titer or if there's increase in the thyroglobulin levels. But there is no benefit to know what's going on before the operation. So no benefit to do a preoperative thyroglobulin. It will not make any difference. This is different from the calcitonin. The calcitonin, which is in medullary thyroid cancer, we need to have a baseline calcitonin before the operation. Because after the operation, it is very, very common that the calcitonin doesn't go back to undetectable. There is some sort of calcitonin there because of the nature of medullary thyroid cancer, that there are some tissues of medullary thyroid cancer should be there. I mean, even you do the treatment, you will have some tissues or cells still there. And the calcitonin, there might be some sort of calcitonin after the operation. So you have to know the baseline before the operation and after the operation to compare. That's different from the thyroglobulin. Radioisotope scanning, I think no need for that at all. We do this when we have an overactive thyroid. There is no need to do that when you have euthyroid status, and no benefit for diagnosing any cancer, because some people doing the technetium 99, or I don't know why. Some people do that as like a routine investigation or in the thyroid, but that's not right. Calcitonin screening for any thyroid nodule, it is controversial. And I mean, it's not a baseline calcitonin medullary thyroid cancer. I'm talking about when we have a thyroid nodule, do we do a routine investigation calcitonin level to detect if there is any medullary thyroid cancer? It is controversial, and it is cost benefit, I think it's not of value, because medullary thyroid cancer is very rare. It's about 3% of all thyroid cancer, and thyroid cancer 1% of all cancer. So it is extremely rare to pick up these medullary thyroid cancer if you do screening, normal screening for calcitonin. So I do not recommend that as well. Then I'd like to highlight about the scoring system in the ultrasound. So we have what I'm adopting is the or here in England there is the UK grading system, but we have different grading system like the American one, the European one, and they are different in some criteria. But these are the general criteria for the thyroid nodule. So U1, we have 1, 2, 3, 4, 5, and it's important to have a numerical scoring system. So it's easier to make a plan and protocol of treatment depends on the numerical scoring system. Because if you have description, sometimes the description, you know, the language may be sometimes confusing, and you can make a decision and it would not help in decision making if you have just a description. But we have a scoring system to make it easier. So one which is normal thyroid tissues. Normal thyroid, this is like a gray color. The gray color is the echogenic. I mean, when you isoechogenic, when you do the ultrasound scan, when it is grayish color, with like the thyroid parenchyma, it is grayish in color. So this is echogenicity, the normal echogenicity. When it is hyperechoic, when you say hyperechoic, so it is white in color. When we say hypoechoic, it is black in color. What is cancerous to us, or what is suspicious to being cancer in us, when it is solid and hypoechoic? So when we have a nodule which is solid, not cystic, and black in color on the be aware that black in color means hypoechoic, because the cyst is very black in color. The cyst is called anechoic. It doesn't take any echogenicity. The cyst has fluid, so it is jet black in color. This is different from the hypoechogenicity, which is less gray. So if solid hypoechoic, that's grade 4 and 5. All of these are solid and hypoechoic. But if you have calcification, which is white in color, preferably it's still in the grade 4, but if it is central calcification, it is grade 5. So this most likely cancerous. And also the other criterion which is important when you have the nodule is taller than wider. So when you do the ultrasound, the anteroposterior diameter, taller, but I mean by taller, anteroposterior diameter, not the superior to inferior diameter. No, I mean because the patient laying down, you do the ultrasound. So the taller means it is the anteroposterior diameter is taller than the horizontal diameter. So this indication also, or a good indication that there is a high possibility of being cancer. So if you have central calcification and there's globular calcification, there's much more with the medullary thyroid cancer. And if you have taller than wider, that's more likely to be cancer. I'm talking about the solid hypoechoic nodules. Yeah. If you have internal vascularity, not peripheral vascularity, if you have internal vascularity in a solid hypoechoic, that's also an indication that there is a high possibility of cancer. This is the suspicious side, and this is the benign side. So U1 is normal. U2 when it is benign. And benign, you have benign nodules when it is hyperechoic, slightly hyperechoic, sometimes isoechoic. Hyperechoic, slightly whitish, or more, I mean, better than the surrounding parenchyma regarding the whitish color. There might be some cystic degeneration as well. This is called the honeycomb, spongy form, and this is the most common description that you'll find it in a descriptive report saying spongy form. If it's a spongy form, it is benign, yeah? And if you have a peripheral calcification and hyperechoic, you have a peripheral calcification hypoechoic, that's U4. But if you have it in hyperechoic, that's U2. Okay, so we are talking about the benign here. Then we have some intermediate, like we have mixed cystic and solid nodule with some vascularity. This you can tell it is highly suspicious or it is low suspicious. So we put it in the intermediate U3. You can see here this is a nodule, and it is jet black in color, and this is purely cystic. This is completely benign. So in these patients, we send him for a fine needle, not for the diagnosis, purely cystic. He will aspirate the fluid, and then we discharge the patient. No need for further follow-up. Also, this patient has, you can see this is solid here, solid component, and we have some cystic degeneration. That's what's called the spongy form. And you can see the echogenicity here is not hypoechoic. We can say it is isoechoic. Isoechoic with a mixed, cystic and solid components. Spongy form, this also benign. This is what's called the night appearance, night like a prince, yeah, because it's white. And it has hyperechoic. That's hyperechoic with some halo round. That's also indication of benign nodule. So I discharge this patient. It is U2. If this come back as U2 in the description, so discharge the patient. So what are the suspicious criteria? As I said earlier, it is solid, it is hypoechoic, the diameter anteposterior more than the transverse diameter, it has a regular margin. This is not important actually. A microcalcification has a high positive predictive value. It is the most specific sign here. It's microcalcification. It is an indication of papillary thyroid cancer, and it is globular appearance. It is indication of medullary thyroid cancer, but it has a high positive predictive value, a good positive test. The internal, if you have internal vascularity, also that is a suspicious criteria. If you have a lymph node, this also suspicious criteria, but it's not important as well. But yeah. All of these criteria are suspicious, but no one diagnostic except if you have an extrathyroid extension. If you have a lesion in a thyroid with extrathyroid extension picked up by the ultrasound, this is a diagnosis of cancer. But all of that are high suspicious sometimes, but not necessarily to be cancer. Still, there is some false positive results in there. Yeah, the size is not important. Yeah, size is important when you diagnose cancer. I mean, when the cancer is already diagnosed, then size is important. Size does matter. Yeah, T1 is different from T2, different T3, it is 2 centimeter, 4 centimeter, and so on. So it is important when you diagnose cancer, the size is important. But it's not important for diagnosis of cancer. I mean, if you have a thyroid nodule, not yet diagnosed, size doesn't matter at all, because a tiny one, like 1 centimeter or ½ centimeter, could become cancer, and a big one, 5 centimeter, could become cystic, purely cystic and benign. It's completely benign. So size doesn't have any correlation with the being cancerous or not. But once diagnosed cancer, then the size make an effect. You can see here, this is the nodule. You can see the micro. It is hypoechoic with a microcalcification. This is central calcification, and it is taller than wider as well. So this is most likely a cancer nodule. And also this one as well. They have some. This is eccentric nodule here with central calcification as well. So it is solid. It is solid, hypoechoic with a central calcification, maybe some cystic level here, but it is mainly solid eccentric. Eccentric solid hypoechoic with a central calcification. It is a U5 nodule as well. So this U5 and this U5. There are different types of pattern vascularity. Someone may say, why I'm describing the ultrasound. Maybe it's not important, but it's important when you stay in the, or you were set in the MDT, and you have to have some idea what the people talking about. And you can sometimes happen every now and then. You correct sometimes to the radiologist. Okay, I can see that it is much more to like a U4 or U3. So you should have you know something about the ultrasound. You shouldn't be an expert, but you should have you know, some basics about how the nodules look like. There's different vascularity. When you have no vascularity or very minimal like that, that's nothing. Unlikely to become cancer. When you have a peripheral vascularity, we call it like a fire ring. That's also depends if it's hypoechoic or hyperechoic. This mixed cellularity also may happen in a U3, but internal vascularity happens in a U5. If it happens in a solid hypoechoic with internal vascularity, that's U5. This is a kind of, you see, this is that parenchymas there, and you have hypoechoic nodule, solid, yeah, solid hypoechoic, so it is U4 or U5, but you have mixed cellularity, not internal vascularity, so this make it a U4. If just you have internal vascularity, it make it like U5. This kind of U3 nodule. So you can see here, it is hyperechoic nodule with mixed cellularity. So it is U3, hyperechoic, whitish a little bit with mixed cellularity. So you can tell it with a mixed cellularity. You can say it's oh yeah, it is a U2, and this is not U5 as well. So it is something in the middle. It is intermediate. This is the same thing as well. You have a mixed component of a solid component and a cystic component with a mixed vascularity. So you make it like a U3/U4, U3. We have the American system is different a little bit. I'm not too expert into the American U grading system, but they don't have normal. That's one thing. They're starting from the benign, and they have very low suspicious, intermediate, and so on. And they take the size into account, but because they don't do any fine needle aspiration if it is less than 1 centimeter. Even if the nodule has a lot of features of cancer, but if it is less than 1 centimeter, they didn't do any fine needle. But this is different from the UK system, actually. Sometimes we have a 5 millimeter. Maybe it's difficult to do a fine needle in a 5 millimeter half centimetric nodule, but we do fine needle for those. So we have a different protocol, or the UK different protocol from the American protocol. But we can generally say that when you have a benign, the risk of malignancy is very low. And when this kind of a U3, U2 is less than 3 centimeter. This kind of a U3 is 5 to 10% that risk of malignancy. And U4, there is a chance of 10 to 20% risk of malignancy. And this kind of a U5 is 70 to 90% risk of malignancy. It's not 100%. There is still a chance of 10% if it's not a malignant. But there's a very high suspicion of malignancy. And U4 is 20%. There is a chance of 80% in U4 to become non-cancerous. Okay, so this is the another system, the European system. I think this. I have seen some reports in Egypt using the Thyroid system. I think the old school pathologists in Egypt used the descriptive technique. They described. They didn't give a scoring system, which is not a key recommendation. Actually, I think we have to have a scoring system. Some people, I think the pathologists now using the European system, Thyroid system 1, 2, 3, 4, and 5. It's similar to U1 to 5, but they don't take the Doppler. I mean the vascularity into account. When they do the ultrasound, you don't do Doppler, so we didn't do any vascularity into account. And also, if there is lymph node, they didn't take it into account. So it's slightly different from the UK as well, but it's similar. This is maybe of no value. It has been reported back in 2010, 10 years ago, some articles about elastography, but it didn't gain any popularity. But you can see here from, it depends on how is the elasticity of the nodule of the thyroid. So when it is green, it is highly elastic. That's a good sign. When it is, blue, it is not elastic at all, and give it much more scoring towards cancer. But I haven't seen anyone. I haven't seen a report like that. I just bring it from the literature. The same thing happens when you do the fine needle aspiration cytology. So we still have a scoring system, and it is recommended to be a scoring system as well. the fine needle aspiration cytology can be used in the diagnosis of specialist lymph nodes, but I would rather, when we have a lymph node, to use a core biopsy. It's more yielding. For thyroid, go for the fine needle. For the lymph node, go for core biopsy. Some people when do the, but it's not common in UK. Actually, maybe it's much more in the United States. Then when they do the biopsy, they measure the thyroglobulin. From the lymph node. If you would like to know this lymph node, a reactive lymph node, benign reactive lymph node, or metastatic lymph node, they measure the thyroglobulin in the fine needle aspirate and see if it is high thyroglobulin level or no. The other thing that also it's not used here in UK is the molecular analysis. That in some suspicious cases, not the highly suspicious cancer, but in the intermediate group, they do molecular analysis. When they take the aspirate, they send it for molecular analysis for some genes, and if it shows positivity, they proceed to surgery. If it shows negativity, negative, so it is benign, most likely benign, and so they don't go for surgery, maybe close observation or so. But I don't have too much experience in the molecular analysis. As I said, the scoring system helps in accuracy and audits and research. And makes the protocol, to find a protocol depends on the scoring system, is easier, and so we have a protocol to follow. What's the drawbacks? The fine needle sometimes comes back what we call a Thy1, which is inconclusive. It's just you bring some cells, you can make a diagnosis from these cells. And also follicular, the papillary, it has papillary. When it takes few cells and shows papillary cells, that's diagnosis papillary cancer, so it's a Thy5. But if you take follicular cells, you can tell this follicular cell is benign or malignant, because you can differentiate from just the appearance of follicular cells. You need to know how much of these follicular cells, and if there is any capsular invasion, any vascular invasion. So you need more tissues, more than just cytology. So you need histology, not cytology, to identify the follicular type. The fine needle can differentiate between the hyperplasia, follicular hyperplasia, which is completely benign, and the follicular adenoma, which is a benign tumor, and the follicular cancer, and what's called the follicular variant of papillary thyroid cancer. The scoring system, Thy1, it is non-diagnostic. As I said, you bring some cells, you can make any diagnosis, and the risk of malignancy in these is about 5 to 8%, something like that. And if it is purely cystic, if the aspirate is purely cystic and the nodule is purely cystic, that's benign. I'm talking here if 14% of cystic, I mean if there is mixed solid and cystic component. If mixed solid and cystic component and bring just the fluid, you can take few cells, the risk of malignancy is up to 13%. But again, if it's purely cystic nodule, it is benign. Yeah, no fear in discharging these patients. Thy2, which is completely benign cells, non-neoplastic, normal cells, less than 3%. And these patients, if Thy2 comes back as benign, so I discharge the patient provided that the ultrasound also consistent with the ultrasound results. So if it's U2, which is benign, Thy2, or U3, Thy2, most likely it is benign. But I will discuss this in details in just a few seconds. Thy3, as I said, when you take few cells and you can differentiate between the follicular hyperplasia or adenoma or carcinoma, so you have to go for diagnostic hemothyroidectomy. So you have to go for tissue pathology for diagnosis. The same thing is called Thy3A, A for atabia. And sometimes, if there's some sort of thyroiditis, like in Hashimoto's thyroiditis, or some sort of thyrotoxicosis there is some sort of thyroiditis inflammation. And when you take the cells, it doesn't look normal, it looks atypical because of the inflammation. And this also, Thy3 carries a chance of malignancy. So Thy3F and Thy3A carries a chance of 30% malignant, but 70% chance of benign. But as I said, Thy3A, when it is in the background of thyrotoxicosis or Hashimoto's thyroiditis, we usually do not rush into surgery for diagnosis. Though there is statistically a chance 30% to become cancerous, but on the background of thyrotoxicosis or Hashimoto's, we didn't rush into the surgery. But if it is atabia without any background of inflammation, then there is a chance of 30% malignancy now becomes more reliable, and we can go for tissue diagnosis. I mean by tissue diagnosis, a surgery. It's not no role for frozen section at all. Thigh 4, the other way around. When we say the thigh 3, 30% chance of malignancy and 70% benign, with thigh 4, 70% malignant and 30% chance of being benign. So these patients also need a diagnostic chemothyroidectomy. Thigh 5, when you take a few cells come back as cancer, it is almost 100% is cancer. But it could be papillary, it could be medullary, it could be anaplastic. So thigh 5 could be any of these. Thigh 3 contains the follicular type. And so for thigh 3, we go for therapeutic operation. So what we can do, then we have a protocol. U-grade system in combination with a fine needle. So as I said, 5% of thyroid nodules are palpable, 5% are malignant, 95% are benign. The chance increased by 40% in the background of radiation. So if you have a U2, thigh 2 cytology, discharge the patient. And I don't know why we do a fine needle actually in U2 nodule. In U2 nodule, no need for doing any fine needle. But if it happens that the thigh 2 U2, discharge the patient. If you have a U3 and thigh 1, a U3 nodule and thigh 1, or U4, U3 plus, U3 or 4 or 5, and thigh 1, then you have to repeat the biopsy, especially if U4 and U5, repeat the biopsy. If U3 and thigh 2, then you have to discuss this in a multidisciplinary team again. Say, okay, it is U3, there is intermediate in the scan, but it is completely benign in the fine needle. So what's the situation now? That's why the importance of the multidisciplinary team. We'll discuss again, we'll chat. Okay, it looks, no, the nodule looks fine. Or the pathologists say the pathology fine needle looks fine. Or it's no chance of malignancy in there. If U3 thigh 2, what I do is send not discharging the patient completely, but send the patient for another ultrasound in 6 months' time. And for this interval changes, we see if any changes of that nodule getting more malignant or shows any sinister features. But that's what I do for U3 thigh 2. But after 6 months, if it's a stable nodule, I discharge them. No need for further follow-up. But if it is U4 or U5 and thigh 2, there is a big discrepancy here, and we have to send the patient again. If you have a high suspicion clinically and radiologically from the ultrasound, then you have to go for another biopsy, fine needle aspiration cytology. So this is the protocol. Do an ultrasound. It is U2, 1, 2. Discharge the patient. U3, U4, U5. Thigh, if it comes back as thigh 2, then we have, if it comes back as thigh 2, then we have to review the clinical point of view, ultrasound point of view, discuss in the MDT. If low suspicion, if it is U3 and thigh 2 and low suspicion, myself, I will send them for another 6-month follow-up scan, and if it's stable, I discharge them. If it is highly suspicious, I will repeat the fine needle again. And if it comes back as thigh 2, then I will discharge. I mean, if it is U4 and thigh 2, and every time it comes as thigh 2, we have to discuss in multidisciplinary team and make a decision then. If it is U3 and U4 and U5, thigh 1, the same thing, repeat the fine needle aspiration cytology. You have 3 possibilities. If the thigh 1 or thigh 2, and in the background of suspicious nodule in the ultrasound, review clinical ultrasound MDT and see if there's low suspicion, high suspicion, take it from there. Any thigh 3, you have to do diagnostic chemothyroidectomy. Thigh 4, diagnostic chemothyroidectomy. Thigh 5, it is cancer, so you have to do a therapeutic treatment. What is incidentaloma? Incidentaloma, when we have incidental finding of nodule. And sometimes the patient do a CT scan for any other reason, for chest, abdomen, whatever, and they have an uppercut to the neck and found a thyroid nodule there. Usually the CT scan is not sensitive in picking up the features of the nodule, so it usually underestimates the nodule. And but the ultrasound is more sensitive. So whenever there is a CT scan incidentally found a thyroid nodule, I send them for ultrasound, and most of them comes back benign, but ultrasound more sensitive in picking up any features than the CT scan. The things is different when you have a PET CT. The patient has a cancer, for example, for the pelvis, and the PET CT, and the PET CT shows a thyroid uptake in the one of the nodules. So there is a chance 30% this uptake is malignant. So it is a high risk, and these requiring an urgent ultrasound plus fine needle aspiration cytology. So if this incidentally found in a CT scan, no need for urgent ultrasound. Yeah, just do a routine ultrasound in 3-6 months time. But if there's a PET-CT picking up the thyroid nodule, you have to upgrade the patient to cancer pathway, or you have to do an urgent ultrasound plus fine needle aspiration cytology, because there is a risk of 30% malignancy. Yeah, sometimes incidental finding happens when you do a thyroidectomy for any other reason. For example, a patient with a large goiter with a compressive symptoms, you did a total thyroidectomy, and then with thorough investigation, thorough examination histopathologically, they found micropapillary thyroid cancer. And this happens in about 5 to 10% of cases. Previously, they call it histological surprise, that we take it for benign, then comes back as cancer. Most of them are microcancers, less than 1 centimeter. Sometimes also microfollicular, minimally invasive follicular, or medullary thyroid cancer, small medullary thyroid cancer. The prognosis of these incidentally found, I mean, apart from the PET CT, but incidentally found thyroid cancers, nodules, the prognosis is very great. Is up to not 100%. So sometimes if you have a microcarcinoma, you have a total thyroidectomy, you remove it for compressive symptoms, and comes back as a microcarcinoma, less than 5 millimeter or so, discharge the patient. Even if it is cancer, discharge the patient. No need for further follow-up for these. It is very tiny. Prognosis is 100%. The local regional, local regional metastasis is very rare. So I'm going to come in details of how to manage the different types of cancer. We have the differentiated thyroid cancer. So differentiated thyroid cancer includes the papillary thyroid cancer, follicular thyroid cancer, follicular variant of papillary thyroid cancer, and Hurther cell carcinoma. These are the differentiated thyroid cancer. And the diagnosis, when we have Thy3F, Thy3A, and the fine needle aspiration cytology, with Thy4, we go for diagnostic chemothyroidectomy. If the Thy5, we go for surgical, therapeutically, surgical removal. The surgery, what is the surgery? That's a question. Do we go for hemi or go for the total? So we have criteria. So if the tumor is T3, is more than 4 centimeter, and has extra thyroidal extension, and as in T4A or T3B, or more than 4 centimeters, so it is T3, or it is multifocal, or it is bilateral, or there is lymph node metastasis or distant metastasis. All of these criteria are adverse criteria. They are not a very good criteria. If the tumor is multicentric, bilateral, there is some extra thyroid extension, there is a background of family history, distant metastasis, lymph node metastasis, do total. There is no question. This is the good medical practice. This is the recommendation. Do total in these cases. There is no questioning there. But the questioning happens when you have a tumor is less than 4 centimeter. It is more than 1 and less than 4. I will talk about the micropapillary later, but the group is between 1 to 4. What to do with a thyroid nodule, cancerous, Thy5, 2 centimeter? Do we go for total or go for hemi? Actually, if you have no other adverse factors, like the age of the patient is young, there is no family history, no history of exposure to radiation, no distant metastasis, no lymph node metastasis, no extrathyroid extension when we, even by the ultrasound, or even post-operative, you did hemithyroidectomy and there is no extrathyroid extension, and the tumor is 2 centimeter, we have to discuss an MDT. but most likely hemi is okay. Yeah, but if you have another adverse of these adverse effects, if the age is more than 50 years, the patient old age, there is some microscopic extrathyroid extension, if there is distal metastasis or lymph node metastasis, you have to go for total thyroidectomy. Yeah, but these are the this group which have no adverse effects, 2-3 centimeter, more than 1, less than 4. Then you have to discuss with the patient and in the multidisciplinary team whether the patients need hemi or total thyroidectomy. Yeah, both options are available. There is no strong recommendation to any one of them, but you'll go for hemi if just maybe 2 centimeter with no other factors. But if there is other factors, you have to go for total. Yeah. There is multidisciplinary team and what's called personalized decision making. Personalized decision making means that there is no strong evidence to what to do no strong evidence like a level 1A evidence that what to do in that scenario. So in these cases, we have to tailor the decision, depends on the patient situation, depends on the tumor factors, the histology factors, many factors that will swing or shift our decision whether to go hemi or total or change our decision. So this is called personalized decision making. So that it means that there is no strong evidence to take that decision. It's not like this. This is strong evidence. Tumor more than 4 centimeter, multifocal, or bilateral, or there is distant, or lymph node metastasis. No question. Go for total thyroidectomy. Then after you treat the primary tumor, then the next question comes: what we do for the lymph node? So if you have a positive lymph node, I'm talking about the central compartment lymph node, go for therapeutic central neck compartment dissection, level 6 and level 7. Okay, if there is N positive, N1A. If there is, if this N node, so if this N node, I mean N0, no lymph node metastasis. So do we go for prophylactic central neck dissection or no? That's a question. So there are criteria here. So if the patient has no lymph node metastasis and the primary tumor is classic type histologically papillary thyroid cancer, I mean it's not a tall cell or columnar cell or this other types, and the patient's young, less than 55, unifocal, okay, less than 4 centimeter, no extrathyroid extension, because any extrathyroid extension, it means that there is a risk of the central compartment to be affected. There is a risk, there is a micrometastasis in the lymph node. But if you have definitely no extrathyroid extension, the tumor is small, less than 4 centimeter, classic type of not aggressive behavior papillary thyroid cancer, no need, not recommended to do a prophylactic central neck compartment. Because prophylactic central neck compartment carries a risk of taking the parathyroid as well. And you may end up the patient with hypocalcemia. So there are some comorbidities here. So it is not recommended if it is straightforward. Otherwise, if you have any other features, like patients, old patients, or multifocal, or so on, then we have to discuss this, and there is a possibility we go for the prophylactic central neck compartment. Why it is not recommended to do a prophylactic central neck compartment in these cases? Because if the patient is clinically N0 and the relative risk of the patient has to become an N1 is 2 to 4%. That's very low. I mean, later on, the patient has lymph node metastasis is 2 to 4%. So no, not recommended to do any prophylactic neck dissection in node patients. Then the question will arise: do we do prophylactic central neck compartment unilateral or bilateral? Yeah, it's a matter of question that both answers could be fine. There is a chance of 13 to 50% chance of contralateral or bilateral metastasis, and there is some papers saying there is no significant difference in comorbidities or thyroglobulin concentration if you do bilateral, but I don't know. I think bilateral can carry some comorbidities. But anyway, what I routinely do is we would do the whole central compartment bilaterally. Yeah. Then the question will arise, what we're going to do with the lateral neck extension. So the primary tumor has been treated, total thyroidectomy, if it is more than 4 centimeter, or lymph node or distant metastasis or extrathyroid spread, as we said. So you treat the primary tumor, then central neck compartment, yeah? Then the question will arise, what we'll do with the lateral neck compartment. So we have positive lateral neck compartment, we have to do therapeutic neck dissection, selective neck dissections. What we do is level 2, 3, 4, and 5B. I do that as a routine. 2, 3, 4, and 5B. But there are, it's not recommended to do any levels of 1 or 2B or 5A. 5A is above the cricoid cartilage, level of the inferior border of cricoid cartilage. Or sometimes some people describe it's above the spinal accessory. So no need to, it's not the tumor behavior to affect the 5A or 2B or 1. Unless if there is an evidence radiologically by the ultrasound that there is some lymph nodes there, then you have to take this lymph nodes as well. But what we do routinely, 2, 3, 4, and 5B. This is in cases of positive, N1B positive. I mean, there is a lateral neck extension. But if the patient is in node, I mean N0, so prophylactic, if the patient is has no lymph node metastasis at all, not in the central compartment, so the prophylactic lateral neck dissection is not recommended because difficult. The patient has N0 and no involvement of the central and have lateral compartment. That's difficult. The tumor should usually the behavior that affects the central compartment than the lateral compartment. So the question will arise if the patient has just N1A involvement of the central compartment. Do we do the prophylactic? Again, discussed in the multidisciplinary team, evaluate personalized decision-making, discuss what's the tumor behavior, the tumor aggressiveness, the histological type, the other adverse effects, the age of the patients, but the N1B carries 80% chances of central node involvement. Yeah. So it depends actually. If the central compartment involved, not necessarily doing the prophylactic lateral compartment, unless if there is some adverse, adverse effects or adverse factors. Sorry. What is the micropapillary thyroid cancer? So micropapillary thyroid cancer is less than 1 centimeter. This 1 centimeter less. This is the micropapillary thyroid cancer. So if it is micropapillary thyroid cancer, which is unifocal, just one focus, no other risk factors, it is 5 millimeter or less, so it's less than half centimeter or less, and it's not incidentally found by PET-CT. It is incidentally found. It is not multifocal. It's not an aggressive histology. It's not like a tall cell, a columnar cell, or diffuse sclerosing papillary thyroid cancer. There is no extrathyroid extensions or no risk factor. Then unifocal micropapillary thyroid carcinoma, just do hemithyroidectomy or lobectomy and discharge the patient. No follow-up for this. Though it is a cancer, no follow-up, discharge the patient. But if the patient micropapillary thyroid cancer, multifocal and bilateral, go for total. Yeah. Then the question will arise with hemi or total with a micropapillary thyroid cancer with some risk factor from above. For example, if it is 7 millimeter, or it is a PET positive, or it is some aggressive histology. Do we go for hemi or go for total? That's a question, and this should be discussed in multidisciplinary team. And again, personal decision making. I would rather, if presence of any risk factors, I would go for total. Of course, all of these scenarios we have to discuss with the patient and discuss the surgical benefits and risk of the operation and see what the patient also would like. It's not our decision. It's not the MDT decision only. It is the patient decision as well. So we finished the whether it is total thyroidectomy or hemithyroidectomy for micropapillary cancer. So if it is a lymph node metastasis, if there is a central compartment involvement, we do a therapeutic neck dissection. If it is micropapillary cancer with multifocal extrathyroid extension, we do prophylactic. We may consider prophylactic central compartment neck dissection. Otherwise, we don't do any prophylactic neck dissections. If it's not multifocal and no extrathyroid extensions, no need for doing any prophylactic neck dissection. Then we have the follicular thyroid cancer. The follicular thyroid cancer, if it is more than 4 centimeters, again, it is total thyroidectomy. Strong recommendation. The question will arise whether it is less than 4 centimeters, what we do. So if there is no risk factor, age of the patient, histologically, there is no, in the follicular, there is no invasion of the blood vessels, it's not widely invasive, no lymph node metastasis, no distant metastasis, no factors of these. So we may consider hemithyroidectomy. And in that case, the patient has, it's no need for radioactive iodine afterwards because you did just hemithyroid. But if there is any risk factor, we do a total thyroidectomy. Yeah. So if it's more than 4 centimeters, total thyroidectomy. If less than 4 centimeters, depends on how are the risk factor up there or not. No need for prophylactic neck dissection in follicular thyroid cancer in cases of N0. I mean, if N0, don't do prophylactic neck dissection because the chance is very low. It's about 1 to 8%. Unlike the papillary, one of the characteristics of papillary thyroid cancer, it has a lymph node metastasis, common lymph node metastasis. That's why we're talking about the prophylactic neck dissection. But in follicular thyroid cancer, it doesn't have that behavior of lymph node metastasis. It's much more behavior of distant metastasis, actually, because of the vascular invasion. So it may go for distant metastasis, but not for lymphatic metastasis. So no need for prophylactic neck dissection. The other subtype is previously the considered like subtype follicular thyroid cancer, but now it is a special entity called Hürther cell. And these are the Hürther cell characterized by this granular cytoplasm, eosinophilic cytoplasm. And it has a poorer prognosis than the other types of differentiated thyroid cancers, and has some sort of lymph node metastasis. And the Hürther cell carcinoma, unlike the follicular cancers, shows a low response to the radioactive iodine. Follicular cancer, by default, it is follicle. It is thyroid follicle. So one of its characteristics that it has this high uptake of iodine. So the follicular cancer is the best cancers to be treated by radioactive iodine. Hürther cell, though it has some sort of follicular element in it, but it has low response to the radioactive iodine. If it is more than 1 centimeter, go for total thyroidectomy. If it is Hürther and more than 1 centimeter, go for total thyroidectomy. If it is less than 1 centimeter less, then the question will arise whether hemi or total. Because of the relatively higher instance of metastasis, I said in the follicular, no need for prophylactic neck dissection, but it's different in the Hürther. We may consider the prophylactic neck dissection, according, of course, as the age of the patient and aggressiveness of the disease and so on. But generally, the Hürther cell is not of that good prognosis. Then I'd like to speak about the terminology of surgery. I don't know if I'm fine with time. So hemithyroidectomy is when we take one lobe of the thyroid plus the isthmus. Total thyroidectomy, 2 lobes and the isthmus and a pyramidal lobe. The pyramidal lobe is the extension, the upper extension of the thyroid in the midline. It is part of when the thyroglossus tract goes down. There is some. Don't forget that in the surgery. It's important because some people do the thyroidectomy and forget about the pyramidal lobe. The pyramidal lobe is present in about 30% of cases, so you have to take it as well. Yeah, because it contains thyroid tissues as well. And near total lobectomy, that we in certain scenarios we can leave tiny tissues. For example, if you have too concerned of damaging the recurrent laryngeal nerve because the tumor is stuck to the recurrent laryngeal nerve, you are relatively justified to leave some tissues there over the nerve after trying all your best to preserve the nerve. So we sometimes do near total lobectomy. Near total thyroidectomy when you do near total lobectomy bilaterally, or you do total lobectomy on one side and near total lobectomy on the other side. Subtotal lobectomy and subtotal thyroidectomy, it's an old nomenclature previously used when we have Graves' disease and like to leave like 8 grams and like a thumb, some described like a thumb of thyroid tissues. but it's no more this use. So these, I mean, for treatment of cancer, the ideal is hemithyroidectomy, total thyroidectomy. There is no, unless in certain situations, if you endanger the nerve, you are justified to leave some tissues there. But this is not the treatment of choice at all. The treatment of choice is hemithyroidectomy or total thyroidectomy. So the surgery is, we have to assess the vocal cord mobility beforehand for medical legal purpose, and to see if there is any recantral nerve infiltration. Recantral nerve injury and no higher after re-operation for recurrent disease or central neck compartment. Personally, I don't go for the external branch of superior laryngeal nerve to identify it or skeletonize it, but I will. But I usually divide the superior pedicle close to the thyroid gland, close to the capsule, so I'm away from the nerve. I do not go for skeletonization of the nerve unless if the patient is professional singer or anything like that. So I have to look for the nerve itself, the external branch of superior, but not routinely. Parathyroid gland, we have to preserve it. And if any compromising the blood supply, we have to reimplant it, make a small pocket in the sternocleidomastoid muscle, and put the parathyroid inside. You can chop it to many tiny tissues, so they can gain more blood supply, and put it in a pocket in the sternocleidomastoid muscle. Yeah, just a way of if in case of devascularized. Central neck dissection, level 7. Level 6, because you may damage, devascularize the parathyroid gland, or damage or cause concussion of the parathyroid gland. There might be temporary hypocalcemia. But there is no, I mean, if you compare it to the total thyroidectomy, there is no difference. But personally, I feel there is a difference. Maybe some article saying that, but central compartment carries a higher risk of hypothyroidism. That's my impression. I don't routinely give any Clexane before the surgery, intraoperatively. VTE prophylaxis, just we depend on the mechanical things like the elastic rubbers and so on. But we don't give Clexane unless the patient has a high risk of coagulopathy, like previous history of DVT and so on. This is how I do it. I'll give a short brief how I do the thyroid. Maybe it's not this presentation it's not about the surgery, it's about the decision making in thyroid cancer. But just a brief how we do the surgery. I use the NIM tube, the nerve the intraoperative monitoring, and this is the surface electrode here. It is important medical legally, and it's quite useful sometimes. But don't depend on the nerve monitoring for exploration or for anatomy. It's not a replacement for anatomy. It just might help you sometimes in the surgery or in the bad situations. I use the ligature, which is a quite time-preserving instrument. Some people using the harmonic scalpel. I liked much more the ligature because it is, it's quicker than the harmonic scalpel. Or you can use the suturing and dividing and suturing, but this makes the time of the operation less actually. I do extension of the extension of the neck, extension of the head, no overextension, but extension to have a proper exposure of the neck. I do marking. I mark the cricoid cartilage here, suprasternum notch here, and in the middle, in between, I do the marking in the operative field. I don't do the marking when the patient's awake, because what I want to know, when we do the patient in the surgical position, the patient is extended, then I can know exactly where I want to make the incision, because the thyroid moves on the surgical position. Because if you extend the neck, this is the position that you will work in, and you want to know exactly where the surgical position of the thyroid, so you make the proper marking and proper incision. Of course, I respect the skin crease. I'm trying to find where the skin crease. I don't do it like a linear like that and make it curvilinear much more. Sorry, it's not my pictures, by the way, but myself, I do curvilinear incision with the skin crease. It gives better cosmosis, and I do it in the surgical field. And then erasing the subplatysma. You can see the picture here, some layer of the platysma. It's important oncologically to go in the subplatysmal plane. Yeah. You have to see the fibers of the platysma and retract it up. Don't go further deep. take some of the tissues. That's not oncologically safe. And some people using the Joules retractor, I use 4 stitches to, to retract the field. And then personally, what I do is dividing the strap muscle. This is the sternohyoid, and in the layer deeper is the sternothyroid. So you have a sternohyoid, sternothyroid. I always separate these into layers. For me, it makes it more spacious. I dissect between the sternohyoid and the sternothyroid all through from above to down, and from the sternothyroid and the thyroid all through from above and down. So this makes the personally, especially with a large goiter, it makes it easier to retract, actually, that you divide the muscles between the muscles and between the muscle and the thyroid. And then I identify where's the upper pole. There's the superior thyroid pole, and I use the ligature for that. It's quick. You do just a few seconds, and then it is ligated. And then identify recurrent laryngeal nerve. It's not here the best presentation to describe the varieties in the recurrent laryngeal nerve, but it's very common to be deeper to the inferior thyroid artery. So I usually trying to find where's the inferior thyroid artery, and it is usually deeper, sometimes superficial, or runs between the branches of the inferior thyroid artery, but it's the commonest, 50%, it is deeper to the inferior thyroid artery. I use skin clips at the end. I think it gives same results as the subcuticular. And I haven't seen any cosmetic problems from using the skin clips. But what's important when you do the skin clips, it's trying to make the edges everted. So when the healing, you go up together. Don't make the edges inverted. No, make them everted. So by this way, you make sure that the cosmosis is the best. What we do post-operative, if you do a total thyroidectomy, you need to give a replacement therapy, but at the same time, this is thyroid cancer. You want the TSH is fully suppressed. The TSH is thyroid stimulating hormone, which stimulates the thyroid. So you want the TSH to be fully suppressed in order not to, grows any the TSH not to grow any of the thyroid remnants, because if the TSH is a normal level, it will stimulate these remnants of the thyroid and may cause a recurrent disease. So you want to keep the TSH fully suppressed. What's the word? Here's the word that's important. When you say full suppression, it means less than 0.1 unit. This is what's meant by fully suppressed. We have 3 grades we have a full suppression and a suppression. We need the TSH in most of cases, it is fully suppressed, less than 0.1 unit. So that's why we have to give the replacement therapy of the levothyroxine relatively on the thyrotoxic side. So we give it 2 micrograms per kg. For example, a patient 70 kilograms, we give them like 150 micrograms of levothyroxine. Or you can give T3, 20 micrograms TDS. But we give levothyroxine usually, and the patient tolerated much better the levothyroxine than the active form T3, the liothyronine, in order for that to keep the TSH fully suppressed. And but in some cases, there is, I'll mention that later, no need to do a radioactive iodine group, no indication. There are some group of patients that no indication for radioactive iodine. So in these cases, you can keep the patient on the TSH, but on the low normal side, okay? On the low normal side. Then we check the calcium. I usually check the calcium 6 hours after the operation and 12 hours after the operation. Some people saying, okay, check the calcium the next day or whenever there are symptoms of hypocalcemia. But I do it two times, 6 hours and 12 hours. So we have like a trending pattern. So we can see if it is getting high, because if you have one reading, you can tell it is temporary hypothyroidism or it is normal. But if you have 2 values, you can say, okay, it's getting better. By the day of the surgery, there are temporary hypothyroidism and getting better by the next day. Sometimes happens. So you have to have 2 readings, I believe. And there are some protocols for correction of any hypocalcemia. If any examination, No need for doing F&E examination to check the vocal cords immediately after the operation. It's not necessary. Even if there is a neuropraxia of the nerve or damage of the nerve, this will not make any difference. What's happened, what's happened. But it's maybe later, because you, like 4 to 6 weeks later, when you do a follow-up for the patient, you can do an examination then. Because if there's a neuropraxia, which happens after the operation, now it's getting better, and you can feel that the vocal cords going back to normal after 4 to 6 weeks. But don't expect that neuropraxia by the next day will improve. So it will not make any difference to do an examination. Some people doing an examination the next day in the morning round. It doesn't make any sense. Oh, that's what I believe, sorry. TG not earlier than 6 weeks post-operatively. Yeah. We do thyroglobulin, that's the tumor marker for the papillary and follicular thyroid cancers. So don't do it earlier before 6 weeks, because it will not returning back to, I mean, we have to give it some time to be completely reduced or become non-detectable. Yeah, and we have to, it's important to use, to have some laboratory, because changing laboratory makes, regarding the thyroglobulin antibodies, makes some changes. I mean, it's important to keep that laboratory that you are dealing with, the same laboratory with the same techniques. The other, then I will go for the other key recommendations. It's the risk stratifications. So we have, according to the American Thyroid Associations, they stratify people into low risk, intermediate risk, and high risk. So the low risk patients, then the patients with no regional metastasis, I mean, no lymph node metastasis, no distant metastasis, no local metastasis. I mean, there is, it's not T3B or T4. There is no extrathyroid extension. And there is no residual, gross residual tumor. And histopathologically, the tumor is classic type. It's classic papillary, classic follicular, nothing worrying that. So this post-operative risk stratification, these patients, if come with these criteria after the pathology assessment, so they are low risk group of recurrence, okay? And the other way around, the high risk group, which has a tumor more than when the tumor is T4, I mean, there is extrathyroid extension, and there is a residual tumor, gross residual tumor, not just microscopic. And M1, there is a distant metastasis. So T4 or R2 or M1, this is a high risk group of metastasis or recurrence. So these patients need a radioactive ablation post-operatively. So after the operation, these patients need the radioactive ablation. There's no doubt in that. They are risk groups. Then there comes groups with intermediate risk post-operatively. If you notice here, we say no local. So it means that no local extension. It is not T3B and not T4A. And the high risk when it is T4. So there are the T3B, microscopic extrathyroid extension. This is an intermediate group. So it's not T4, because T4 will be high risk when there is a gross extrathyroid extension. But we have a microscopic extrathyroid extension. It's a stage 3B. And there is a lymph node metastasis, it's intermediate group, and aggressive histopathology, this intermediate group. So these patients, do they need radioactive I need or not? We will discuss this later. But this is intermediate risk for recurrence. What is the dynamic risk stratification? I just mentioned these words because I want, if you'd like to go into the thyroid surgery, you have to be familiar with these descriptions, with these wording. The dynamic risk stratification, both operative risk stratifications, low risk and high intermediate risk, all these are heavily used in the common language in thyroid subspecialty. So you have to know what is the dynamic risk stratification. So dynamic risk stratification, that means patients had a total thyroidectomy and has a total thyroidectomy, so completely eradicating the thyroid, and there is no any residual tumor afterwards. And then we give the patient a radioactive ablation afterwards. Ablation that's after any thyroid surgery, you will find this microscopic thyroid remnants there. you are not completely 100% removed everything. There is maybe some remnants, microscopic remnants there. So the radioactive ablation is destroying all these thyroid tissues. So by surgery, following by the radioactive iodine, you destroy every thyroid tissues. Okay, then you detect the thyroglobulin afterwards. Ideally, there should no detectable thyroglobulins afterwards, because you kill everything. But the problem with that in these people, we, as I said earlier, we keep them in a full TSH suppression. We give them higher dose of levothyroxine to keep the TSH very low. So we make sure that there is the TSH is not getting high and cause any growth of any microscopic cells there. So we keep them in a full TSH suppression. The problem with the full TSH suppression, that in a long-term full TSH suppression, the patient may develop some comorbidities, may have osteoporosis, and may have fracture, and may have atrial fibrillation, and may have vascular problems. So full TSH suppression is not good on the long term. Yeah, we have to weigh the benefits and risk for that. But to avoid recurrence, we have to keep it in the full TSH suppression. What we do dynamic risk stratification. That after 9 months, 9 to 1 year, we give the patient a thyrogen, which is the recombinant TSH. So the patient keep taking the levothyroxine, but they give them like what we call it recombinant TSH, a synthetic TSH. So by this way, we put the thyroid in, or the remnant of thyroid, or we suppose like a recurrent remnant of thyroid there, like a challenge test, stimulating test. So we give them recombinant TSH, and then we measure the thyroglobulin. The thyroglobulin then is called the stimulated thyroglobulin. So we have the suppressed thyroglobulin, which is the original one, and we have the stimulated thyroglobulin. And if the stimulated thyroglobulin, after this challenging test, there is no detectable thyroglobulin, if the stimulated thyroglobulin is not detectable, this means that patient has excellent response. There is no thyroid tissues there. So you can relax them from the full TSH suppression. This is the excellent response. Some people know the suppressed thyroglobulin is high, and you give them the recombinant TSH, and you measure the stimulated thyroglobulin, and it is very high as well. These patients definitely has a recurrent or residual disease, and these patients need another surgery plus or minus another radioactive iodine. So this is a high risk, or this incomplete response, because the suppressed thyroglobulin is high and the stimulated thyroglobulin is also high after giving the recombinant TSH, and this means that these people has a recurrent disease. Then comes the people in the middle, which the suppressed thyroglobulin is non-detectable. So we have here the excellent response. Suppressed thyroglobulin is non-detectable, but the stimulated thyroglobulin is detectable, but below 10. So these patients has intermediate response. So you can't tell if they have a recurrence or no. So what we do is keep them on the TSH suppression, but not full suppression. We put it in the low normal side. For 5 to 10 years, you should keep them on the low normal TSH with a close observation. But in all these patients, we do, in addition to the thyroglobulin, a neck ultrasound. So the excellent response, the suppressed and the stimulated thyroglobulin less than 1, and the neck ultrasound shows no evidence of disease. We don't do routinely any whole body scan or anything like that. That's not routine. An intermediate group or incomplete response, suppressed thyroglobulin is more than 1 and stimulated thyroglobulin is more than 10. So both are high or rising titer of the thyroglobulin values, and the ultrasound shows residual disease. So this high risk group needs another surgery to resect any residual disease and another radioactive ablation, and the patient should be in the full suppressed dose of full suppression of TSH indefinitely. Intermediate response, that we will keep close observation with them and keep them in a low normal side of the TSH. I will just give a brief about the radioactive iodine. Radioactive iodine, it is there are 2 wording here. The radioactive iodine therapy, RIA, and it's called therapy because it's a treatment for a disease. So treatment for recurrent, residual, or metastasis disease. It's different from the wording radioactive iodine ablation. Ablation means that after thyroidectomy, we ablate the remnants of the thyroid. There is no disease there. We just ablate the thyroid bed. So this is for therapy for the disease, but ablation is just after thyroidectomy. And it's important to do the ablation because it increases, because we have to kill all the normal thyroid tissues, all the cancer thyroid tissues. So the thyroglobulin monitoring should be so we have should be undetectable. So increased sensitivity of thyroglobulin monitoring and subsequent surveillance. Disadvantage of radioactive iodine, that the patient, it is radioactive material. The patient should be isolated in the hospital, social distance, and you know, all of his body fluids, sweats, urine, everything has radioactive material, should be collected, and his samples, blood samples, should be collected in special techniques because of radioactive material. If it is female, there is no pregnancy for 6 months, and also for males, no attempts for any conceptions for 4 months or so. No breastfeeding. The mother should stop breastfeeding 8 weeks before radioactive iodine, and no breastfeeding until the next pregnancy. Sometimes with some techniques, how we do radioactive iodine with a transient hypothyroidism, sometimes cause pulmonary fibrosis, which is rare, and second malignancy, which is rare. Of course, it is lethal to feed to babies. That's why we have to avoid any pregnancies. It is a radioactive material. So radioactive iodine, everything in thyroid has its stratification. So we have definite indication where radioactive iodine, when you have tumor more than 4 centimeters, when you have an extrathyroid extensions, when you have a distant metastasis, these group of people, definitely you need a radioactive iodine, no questioning. People who no need for radioactive iodine, no questioning. If the tumor is micro, it's a micro carcinoma, it's 1 centimeter less, and histology is classic type, and there is no extrathyroid extensions, and a minimum invasive follicular thyroid cancer without angiogenesis. So these are criteria, no indication for radioactive iodine. Then anything in between is, you know, it needs a multidisciplinary team and personalized decision making, and see what's the adverse factors and risks, and then we stratify the patients accordingly if they need a radioactive iodine or not. For example, one of these, if the patient has a lymph node metastasis, do we need a radioactive iodine or not? If the patient completely removes the total thyroid, completely removes the lymph node metastasis, and you are sure, do the patient radioactive iodine or not? This comes in this category, and this uncertain indication. There are different protocols to prepare the patient for radioactive iodine, and I mentioned that because it's part of our job, because we did the thyroid surgery, and you have to prescribe afterwards the medication for the patient. What we do is I give the patient levothyroxine, 2 micrograms per kg per day, and the patient should carry on using the levothyroxine till 2 weeks before the radioactive iodine. Then we give the till 5 days before the radioactive iodine. Then we give the patient recombinant TSH, and the idea behind that, because we're giving the patient levothyroxine, so the patient has a full TSH suppression. So meanwhile, the patient has full TSH suppression, so make sure the TSH is not increased, the endogenous TSH is not increased, but we need radioactive iodine before giving the radioactive iodine. We need the any remnants in there to grow and increase its uptake to the iodine, so it becomes very hanger to the radioactive iodine. So that's why we give the recombinant TSH. We give exogenous TSH, so this will stimulate any remnants of thyroid, make them very hanger to the radioactive iodine, and so they can uptake all the radioactive iodine, and then radioactive iodine kill all the thyroid tissues. That's the aim. So before radioactive iodine, we have to increase the TSH, whether it is exogenous or the other protocol. We give levothyroxine. Then 1 month before, we start the leothyronine, which is another, which is a T3. And why we do that? Because the half-life of leothyronine is actually 3 days, but it takes 14 days. We can stop the leothyronine in 14 days before starting the radioactive iodine, so the TSH can raise. So when the TSH raise 14 days up to 30 units, then we can increase, we can start the radioactive iodine. So that's the principle, is we give the patient levothyroxine, but because the levothyroxine has a long half-life, so we can't, we can stop it and start the radioactive iodine but after 2 weeks, because there is still levothyroxine in the blood, still T4 in the blood. So we have to use another material which has a short half-life, which is the liothyronine, T3, and then stopping the T3. And when we stop the T3, the TSH will rise, and the endogenous TSH will rise, and this will increase the uptake to the iodine. Then after 2 weeks, we can give the radioactive iodine. Or sometimes we don't give the levothyroxine at all, but give the T3, and the T3 stop it 2 weeks before the radioactive iodine, and again TSH increase, and again increase the uptake to radioactive iodine, and then we can give it in 2 weeks. The patient, of course, should completely stop any diet which contains iodine, like the fish. I give instruction to the patient: stop eating fish, eating any flavors which has this pink color, because it has iodine ingredients. All of these stuff should be stopped. For differentiated thyroid cancer, is a role for radiotherapy. No role as a primary line of treatment. The primary line of treatment is surgery, plus sometimes radioactive iodine, depends on if indicated or not, but no role of radioactive iodine as a primary line of treatment, but can be used as an adjuvant treatment. But also that's not usual. It's very aggressive tumor, very microscopic residue, and it's difficult or impractical to do another radioactive iodine, or the tumor itself doesn't show a good response to the radioactive iodine, so we don't have any other options. So the radiotherapy may be the last option, adjuvant treatment, and used as well as a palliative treatment. Medullary thyroid cancer, I said 3% of cancers, of thyroid cancers in adults, 10% in pediatric. 25% of them are familial, part of men type 2 or men type 3, previously called men 2B, but now it is men 3. Or sometimes not as a part of the men, much endocrinoplasia. It is just familial medullary thyroid cancer. It is autosomal dominant. And that's why the importance of these, because not yourself, but your members of the family may have inheritance. It has poorer prognosis than the differentiated thyroid cancer. Unlike when we say the differentiated thyroid cancer, we said the 55 years of age as a cutoff age. Below 55, after 55, age is not a prognostic factor here, because it happens in children and it happens in adults. So it's not a prognostic factor. The patient presenting with a goiter, presenting with endocrinopathy, maybe presenting with hyperparathyroidism, maybe presenting with pheochromocytoma, flushing, sweating, and there's might be nothing but family history of sudden death, because pheochromocytoma, one of the side effect causes, sudden death causes. So ask about the sudden death in the family, first or second degree relatives, may give us a clue that maybe inheritance in there. The workup, as I said, we do basal calcitonin in these patients. If it is more than 60, this suggestion there is a possibility of medullary thyroid cancer. If it is more than 400, it means there is a distant or metastasis. There is a metastasis there. Sometimes it's not 60, it's not, or 70 or 80. It is like 40 or like 30. This kind of basal calcitonin above the normal, you have then to do what's called stimulating test, what's called pentagastrin stimulated test. Actually, that's not available, to be honest. It's not available in all departments. But it's a kind of a challenging test. You give the pentagastrin, and this will stimulate the parafollicular cells to secrete the calcitonin. And if it is increased to up to 250 micrograms or 500 milligrams in males, this means it is a medullary thyroid cancer. You have to do the workup for, as I said, pheochromocytomas, 24 hours urine catecholamines or no metanephrines, the plasma, the parathyroid hormone, serum calcium. Of course, for the thyroid, you do for ultrasound fine needle. Most likely, medullary thyroid cancer needs an MRI of the neck and CT scan of the chest. And you can do it to the contrast here, yeah, because medullary thyroid cancer is parafollicular cells cancer. It's not follicular cells which has the iodine uptake. So there is no role of radioactive iodine in medullary thyroid cancer. because the cells are different from the follicular cells. It's parafollicular cells. So you get CT scan, MRI. Usually, we request that in these patients because they usually have some metastasis around. If the, as I said, if it is calcitonin is more than 400, that means there is a metastasis. So we have to do the distant metastasis follow-up, bone scan, MRI liver, and CT scan of the chest. These patients and their relatives, after counseling with the relatives, need a RET mutation analysis. We need to know if these patients are inherited and how's the family mutations as well. This is the staging, TNM staging for, the staging for the medullary thyroid cancer. So if it is less than 1, less than 2, more than 2, T3 when there is a lymph node metastasis, T4A when there is extension to the round structures, la trachea or larynx, and so on, T4B when carotid and vertebral body, and stage 4C when there is a distant metastasis. Surgical management for medullary thyroid cancer, all medullary thyroid cancer is the standard. Whether there is lymph node metastasis, no lymph node metastasis, the standard is total thyroidectomy, central compartment neck dissection. What is the medullary thyroid cancer, especially except in some scenarios, but total thyroidectomy and central compartment dissection is the base minimum operation. Whether to go for prophylactic lateral neck dissection is recommended if we have a positive central compartment. So if we have to do the central compartment, whether it is in node or in 1, but in 1A. But if there is in 1A is positive, then it is recommended to do a prophylactic lateral neck dissection. Of course, if you have lateral disease, you have to go therapeutic, but prophylactically, we do this when there is a positive central compartment. Because the risk of when you have a central compartment, risk is 70% in ipsilateral side and 30% in the contralateral side. And the question will arise, do we do prophylactic bilateral or prophylactic ipsilateral side? As I said, it is 30-35% contralateral metastasis. We have to discuss this in the multidisciplinary team. We have to discuss this with the patient, taking into consideration the comorbidities of doing both sides lateral compartments. There is a possibility of injury of spinal accessory, hypoglossal, all these stuff. So we have to weigh the benefit and risk for these. As I said, the only thing that we are justified, we can consider the hemithyroidectomy, not the total thyroidectomy, when it is micro medullary thyroid carcinoma, not less than 1, but less than 5, less than half centimeter. And it's not RET negative. I mean, it is sporadic disease, not a familial disease, and incidentally found. We can go for hemithyroidectomy. Then we can offer the carriers, the other members of the family, after doing the gene analysis. Then we can offer them prophylactic total thyroidectomy plus or minus prophylactic neck dissections. Depends on how's the basal calcitonin they have. If it is very high, you have to go for neck dissection as well. But it depends actually on the mutation. Some mutations, like in men type 3, these mutations requiring, it's very aggressive. You have to do the operation for these children which have these mutations within 6 months of their birth, up to 1 year. But you have to do it very quickly. I mean, within 1 year, you have to do the surgery. Some mutation in the gene analysis, like in men type 2A, you can delay that till the age of 5 years. Yeah, it's not aggressive as in men type 3, because there is also stratification for how the aggressiveness of this. The American Thyroid Association says like A, B, C, and D. D is the worst prognosis, and this with some mutations like in the men type 3. Management of medullary thyroid cancers. We don't need to do full suppression of TSH or anything, because, as I said, it is not a follicular cancer; it's parafollicular. اوكي سوري انا خلصت، قربت اخلص يعني. تاني حاجه اللي هو no role of radioactive iodine, as I said. and the follow-up lifelong, and we have to do the calcitonin and carcinoembryonic antigens. And aplastic thyroid cancer is the worst. It is rare, 3%, happens in old ages, more common in females as well, but happens in males as well. The patients usually have very extensive extensions. You can see here, it is undifferentiated thyroid cancer. It's a spindle type. We have a spindle type histological subtypes. Local spread is very common with extensions to the larynx, to the trachea, to the countertension nerve, esophageal infiltrations, and so on. And as I said, it is from the start, whatever it is, 1 centimeter, 2 centimeter, whatever the size, it is stage 4 from the start. This somehow is the aggressiveness of the disease. And it comes very rare. It comes 1 in a year or 2 in a year. But when it comes like that, and when you go surgery, you always regret going to surgery in these cases because everything is stuck there. So thyroid lymphoma is... as I said, it's lymphoma. You refer the patient to the thyroid industry. The last thing that I want to mention, the personalized decision making. These are the scenarios we come through this presentation regarding the scenarios, which is not strong evidence what to do, but we have some evidence. And like in micropapillary thyroid cancer, history of neck radiation, do go for TIMI or thyroidectomy. You have one adverse factor here, one risk factor here. This, of course, I said, personalized decision making. And if there is more than one adverse factors, you may be shifted towards going for the more aggressive treatment, whether it is total thyroidectomy or doing prophylactic neck dissections and so on. So there are clinical scenarios, different clinical scenarios for personalized decision making. So again, that's the last slide. Sorry for being delayed. The key recommendations, again, important to consider multidisciplinary team, important for TNM staging, use of numerical. You ask your pathologist to score the thyroid nodules into the numerical staging. Ask your pathologist to score the finding aspirations into numerical staging. It helps you in decision making. You have to do a post-operative stratification for your cancers and dynamic risk stratification to release the patients from full TSH suppression and personalized decision making. These are the common language in thyroid now, and you have to know all these, what I'm saying, if you'd prefer to be in the thyroid category. Thank you very much, and sorry for being late. I know it's just a big presentation.
شكرا دكتور باسم على المحاضرة الرائعة الدسمة. يعني مفيش منها محاضرات كتير، وخصوصا لو مصريين اللي بيدوها في حاجة زي الهيد نيك. وفي بقى أسئلة معانا ممكن حضرتك تجاوبنا عليها.
اتفضل. أنا معلش تاني على التأخير يعني.
لا مفيش أي عذر ولا حاجة، دي حاجة كويسة، احنا يعني بنعرف معلومات أكتر. شكرا دكتور باسم.
دكتور باسم، استاذن حضرتك بس تقرا الاسئله اللي موجوده على السكرين ونرد عليها ان شاء الله.
هي هتظهر لي على السكرين هنا ولا اشوفها على الموبايل ولا؟
موجوده على السكرين مع حضرتك في البرودكاست.
sorry. What is your experience of thyroid lymphomas? Rare. I haven't, very few. I can remember one case or so. I think it's like any other lymphomas. Doesn't have any good prognosis, bad prognosis, I believe, but are very rare cases to make a comment on. But thyroid lymphoma are rare. I don't have come across them, I think one case or so, but it's very rare. And I usually refer them to the lymphoma team, so I don't know what's happened next because it is out of the ENT speciality at all. We just do the diagnosis. If the iodine contrast given, you have to wait for 8 weeks at least before starting the radioactive iodine. So it happens. Sometimes we need the CT scan with a contrast because it have better sensitivity to see if any pulmonary nodules or metastasis in the lung. It's better than a non-contrast for sure. But if it happens, you have to wait for 8 weeks. Does this affect the patient outcome, waiting for 8 weeks for the radioactive iodine? I think it's not a big issue. The patients can wait for that period. As per Ghana, you have to have 2 separate Thy2 with at least 3 months interval. So to discharge the patient, only Thy2 needs to repeat FNA. No, if it is U3 Thy2, I have 2 separate Thy2 with at least 3 months interval. So at discharge, yeah, I discharge the patients. You can discuss this in a multidisciplinary team, but if there is a stable nodule after 3 months interval, I usually go for 6 months interval, unless if it is like a U4 or so, I make maybe 3-4 months interval. But if it is U3 Thy2, I wait for 6 month interval, do another scan. If it's a stable nodule, I discharge them because they come back. You are justified. The Thy2, they are benign, nothing to be done further. You can't keep them, in a long-term follow-up. But it's actually, again, it's U4, a U5, and comes back at Thy2, which is unlikely. But if it happens, this is a big discrepancy. U4 and U5 and Thy2, a big discrepancy. It's not like the common thing that you find U3 Thy2. And the ones that you do a follow-up scan 6 months and discharge them afterwards. But U4, U5, you go for another biopsy. And discuss this in multidisciplinary team. This should be a multidisciplinary team discussion, not to be your decision for medical legal, only your decision to be medical legally. So U4, U5, Thy2, keep close observation of them. If it comes back at Thy2, again, discuss this again. I mean, reevaluate your clinical again, evaluate your pathology again, reevaluate the radiology again, because there is a big discrepancy here. And I don't discharge them if I'm completely clear from the pathology and radiology that it is not cancer. When to sacrifice, I don't go for that. I usually, if I have to leave, because the comorbidities of cutting the nerve off, especially if you do a bilateral sides, both sides, there is a possibility of tracheostomy afterwards. There is a possibility of hoarseness afterwards. Not possibility, patients will be hoarse. The possibility of aspiration afterwards. There is some sort of comorbidities the patients will have. So no need to do that. Leave. I think I can leave some tissues behind and give the patient radioactive iodine, because if you leave some tissues over, the patient will have a residual disease R2, and this the group that are eligible for radioactive iodine afterwards, and this will kill these tumor cells. But I don't sacrifice the nerve. It's very precious, to be honest. Undifferentiated thyroid cancer. So it is undifferentiated. You mean papillary undifferentiated thyroid cancer? How to, or anaplastic? What do you mean? How to follow up post-operative PET-CT thyroglobulins are inconclusive. Follow up with the thyroglobulin, and if it is increasing thyroglobulin, then you have to do workup again. You have to do another ultrasound. You have to do ultrasound, and you have to do thyroglobulin. Ultrasound, if it shows any residual tumor, then you have to go back. But both, by basic things, is the thyroglobulin and the ultrasound. And if there is a residual disease, then you can do other scans like a CT scan or whole body scan. But basic sense, thyroglobulin and ultrasound. PET-CT, it's not routinely, I mean, for residual or recurrent disease, we can do a PET-CT. If there is a residual or recurrent disease, to see if any distant metastasis elsewhere. But it's not routinely done for thyroid cancer, only if there is a residual recurrent disease and you are suspecting distant metastasis as well. So you'd like to back up this distant metastasis. I do PTH within 5 hours. If more than 15, I don't care about calcium. If more than 15 hours, I do not care about calcium. Is the question or statement? I don't. Yeah, if it's normal, that's fine. But sometimes you have this calcium is normal, but I like a trend afterwards, because you may have a transient hypercalcemia afterwards. But you are right. I mean, PTH is within minutes a drop, and if it is normal after the operation, it will be normal, and you will have the calcium 5 hours. If it's normal, that's fine. But I usually do 2 readings that just make it consistent. There is Hertel cell adenoma as well, and how to differentiate brown Hertel if present. The pathology question, actually, I don't know. I don't know how they differentiate between malignant and benign pathologically, but I leave that decision to the pathologist, actually. Lymph node, if recurrent lymph nerve lymph node is involved and discovered intraoperative and difficult to dissect, what I do? What recurrent lymph node is involved and discovered intraoperative and difficult to dissect. I don't understand the question. What do you mean recurrent lymph node?
I think Dr. Bassim القصد في السؤال ان هو لو في recurrent lymph node related to recurrent pharyngeal nerve. It's difficult to dissect.
Okay, if it's difficult to dissect, leave it and give radioactive iodine afterwards. What's your advice for tips preserving inferior parathyroid gland? Parathyroid glands and central neck dissections. Yeah, I just follow. I know. Just be very careful in dissection, and I go for the differentiate between the fatty tissues, dissect around, and the parathyroid is dusk red in color, very vascular. If you touch it, it's very vascular. Trying not to devascularize it. Try to be very careful in dissection and keep it. That's what I do. Just trying to dissect very carefully and preserve the glands.
احنا تقريبا كده غطينا معظم الاسئله دكتور باسم، واحنا متشكرين جدا لحضرتك للبرزنتيشن الجميل دوت. احنا عارفين احنا طولنا عليك، بس
لا طولت عليكم، معلش سهره طويله بصراحه، متاسف يعني.
لا ولا يوم، ان شاء الله حضرتك تبقى معانا على طول ومحاضرات تانية اكتر باذن الله يعني.
شكرا.
واحنا متشكرين لحضرتك جدا يا فندم. شكرا.